Hi there, everyone. Welcome to Project Echo, the best practices of aging care. We're so glad you're here. This Project Echo on the care of older adults is a partnership between the University of Louisville Traeger Institute and the Kentucky Coalition for Healthy Communities. And I am Pam Yankulov, the Director of Research and Evaluation at the Traeger Institute. For engagement strategies, we ask that you go on and keep on your video if at all possible. And we do ask that you mute yourself and just go on and raise your hand or go on and put a comment in the comment box or the chat. If you're having difficulty with your sound or your video, you can go on and click on the arrow right next to your microphone and go on and test your system, but don't lose us. Come back to us either by your computer or your phone. We do ask that you go in and put your name and your organization in your Hollywood video square. There's two ways of doing that. You can go on and click on the three little in the upper right-hand corner of your video and click on that, and you will see how you can rename yourself and go in and put your name and your organization and your pronouns. The other way to do it is to click on your participants, find yourself, and click on more, and then go on and rename yourself. It just helps us get a better sense of who is in our community so that we can connect with people we haven't seen in a while. If you're unfamiliar with the University of Louisville Traeger Institute Republic-Based Optimal Aging Clinic, our mission is to help people optimally age throughout their lifespan, trying to help them expand their health span. So we are a workforce development hub. We have several federal grants that are really helping us infuse geriatrics into primary care, as well as infuse behavioral health into primary care and paraprofessionals into primary care. We also have a variety of other grants focused on caregivers and also trying to infuse different evidence-based programs into our project. So we're really trying to help people become interdisciplinary teams around the ideas of how to address whole health. And we also engaged in practice transformation. What I mean by that is clinical practice transformation, where we help outpatient clinics, your typical traditional primary care clinic, as well as your nursing home and your emergency departments to be more age-friendly as well as trauma-informed. And the last thing, we all know that we don't spend the majority of our time in a clinical setting. We spend most of our time in the community. So we also want to make sure that our communities are age-friendly and trauma-informed. And the University of Louisville Traeger Institute is doing this in partnership with the Kentucky Coalition for Healthy Communities. And I think I'm going to be passing the mic to Barbara. Barbara Gordon, is that possible? I saw you shake your head up
Yes.
and down. All right.
Yes, thank you. The Kentucky Coalition for Healthy Communities is a coalition for the entire state who focuses on creating community support systems for older adults in partnership with existing local coalitions and organizations, primarily for the purpose of really helping to make our communities healthy. And then also to develop workforce and concerned community members to empower our communities to become healthier. Thus, our partnership with the University of Louisville Traeger Institute in this particular training space. Thank you.
Thank you, Barbara. So our Project Echo is driven by a few things. It's driven by the six pillars of lifestyle medicine, which include the focus on plant-based nutrition, engaging in regular physical exercise, restorative sleep, avoiding risky substances, positive social connection, and stress management. Additionally, we are led by the 4Ms framework. This framework was developed by the John A. Hartford Program and the Institute for Healthcare Improvement, where the idea is that every time we work with an older adult, we should be focused in on the 4Ms. The first one is what matters most. I don't know if I'm doing a slide before the slide presents, but I'm going to continue. What matters most, we'll be focusing also on medication, making sure that we only, avoid risky, high-risk medications and deprescribe when necessary, as well as having mobility is our third M, focusing on having daily mobility goals. And last is focusing on our mentation, which is our mind and our mood, specifically related to depression, delirium, and dementia. So our fall and winter schedule, we have cognitive decline and dysphagia today. In December, on the 12th of December, we're going to be focusing on the blue zones and healthy aging. On January 16th, we're going to begin the year with a living celebration and beyond with Mona Huff. And then in February, we'll be focusing on the power of purpose and social connections in aging well. What we do is we alternate between lifestyle medicine and other topic areas, and we hope that you can join us for these upcoming sessions that we have. You can take a picture of these, and as you will be hearing from Justin, I'm sure, um, so that you can sign up. If you already signed up once, you probably have already signed up for all of them coming forth in your eye echo, and Justin's giving me the thumbs up, so. All right, if you're unfamiliar with the Project Echo is a telementoring platform. It was developed in the early 2000s by Dr. Sanjeev Arora from the University of New Mexico. He's an MD. He is also a hepatitis C expert, and what he was noticing was that individuals were driving 200 to 300 miles to receive his expertise. And so he wasn't really creating capacity. What he was doing was just taking one office visit away from one person to give it to another person. So what he decided to do was develop this telementoring platform, and the idea is to actually move knowledge, not patients, and build capacity at a local level. So our Project Echoes, there are Project Echoes throughout the world, actually. Many of our federal grants require that we engage in a Project Echo platform. Project Echoes typically have a rhythm where there's usually a didactic, then there's a case, and then there's a teach all, learn all kind of space where all of the different disciplines that are in our learning community work together to try to develop the best recommendations for that particular case. And we learn from one another in this space so that we can bring this information to where we are locally. So thank you all for coming. And if you are interested in receiving an attendance certificate, you are welcome to receive one. You just have to go on and complete the evaluation at the end of the session. And if you are a community worker, health worker, or a social worker who is interested in receiving a continuing education, you must go on and complete that evaluation at the end of the session. Our community health workers are receiving 1.5 CEUs. If you're a certified community health worker from the Kentucky Office of Community Health Worker, and our social workers are able to receive CEUs from Frazier University, who is providing that CEU from the Kentucky Board of Social Work. So thank you, Brescia. All righty, we have our didactic presentation today by Christi Budd. Christi is going to be presenting on safeguarding swallowing, something we all need, improving dysphagia care for older adults. And let me go on and just share a little bit about Christi. Christi has a Master's of Education and a Certificate of Clinical Competence in Speech and Language Pathology. She is a Valdosta State University graduate with 23 years of experience treating children and adults across a wide range of diagnoses and settings. Her expertise includes evaluation and treatment of articulation, language disorders, autism, voice, swallowing, aphasia, and cognition. And we've never had a presentation on this before, so we're very excited that you're here with us today. So thank you, Christi. And you can take the mic whenever you're ready.
All right, thank you so much. I'm excited to be here. Swallowing is something that we don't hear a lot about. We don't realize how important it is until we can't do it. So I've just got some basic information we're going to start with. So swallowing is a reflex. It develops early on at 11 to 15 weeks in the prenatal period. And the purpose of the swallowing, we swallow the amniotic fluid. It regulates the volume of the amniotic fluid in the uterus, which then in turn helps to mature the GI tract. That suck, swallow, breathe pattern is established by week 34. And most people don't realize that swallowing is the most difficult thing that our body does. We do it about 100 times a day. And most of the time when I am trying to do a swallowing x-ray on someone, they look at me and I talk fine. Why is a speech therapist doing this? And so I have to explain to them it's 26 muscles from the beginning to the end of the swallow. And all the muscles that we talk with are the muscles that we swallow with. So we've got multiple structures, as I said, 26 muscles involved in the swallowing. We start at the very front when we put the food in our mouth, our lips and our teeth. Take the food. Our tongue is actually a three-layered muscle that actually goes down to the base of the throat there. It's really long. People think that it's just what the part that sticks out, but it's very complex. Then we go into the pharynx, in the larynx, and then into the esophagus. So we have 12 cranial nerves coming out of the base of our spine, and two of those cranial nerves, 9 and 10, are the ones that are responsible for swallowing. So this is where, when we have a stroke victim, sometimes they cannot get their swallowing done. The stroke has impacted that ability to swallow. I was in a bowling alley one time and just off to the side heard these two people talking. Yeah, they had to check her swallow. I mean, she just had a stroke. She can't talk, not understanding why they had to check her swallow before she could eat. It was really hard. I told my husband it's hard for me to jump over there and say, "Hey, this is why." But I'm just learning that in the public, it's just not something that's well known. So I appreciate being asked to talk about it today. Swallowing is my passion. I love working with patients with swallowing. So we've got 4 phases of swallowing. The oral prep phase. So this is where we put the food in our mouth. The lips seal the food in, the cheeks hold it in as well, and then our teeth and our tongue break down the food and mix it with saliva to form a cohesive bolus, which then gets transferred during the oral transit. The tongue will propel it back towards the pharynx. As the back of the tongue rises up to hit that swallow initiation, it lifts the larynx, the hyoid bone, the whole laryngeal apparatus moves forward to allow the UES, the upper esophageal sphincter, to open in the esophagus, which then receives the food to head to the stomach. Most people don't realize there's a little flap in there that protects their airway, and if that flap, called the epiglottis, is not working, that's when we will start choking. When it doesn't work for different phases, we've got the oral prep phase. This is where, again, with stroke patients or patients with other, different kinds of diagnoses, sometimes that food, if those lip muscles are not strong enough, the food will fall out of the oral cavity. After a stroke, sometimes you'll see people kind of drooling. The corner of that orbicularis oris there is not able to tightly hold the lips sealed, so the saliva will start to fall out. The oral transit phase, there's times they can't hold it in their oral cavity. They may go to swallow, and some of it, they look like little chipmunks, and that's what we call piecemeal deglutition. That's where they can't take all of that food that they have just masticated with their teeth. They can't get it in that cohesive bolus to get it to the back of the throat. If we have that problem as it passes over the back of the tongue into the pharynx and the pharyngeal area, we could have choking. We could also have the penetration and aspiration into our airway if the timing is not right. I tell people a lot of times, trying to explain it to them, that the timing and the reflex mechanism of the swallowing is similar to spark plugs in a car. And so we all know if one spark plug doesn't work, the whole car doesn't work. And it's the same with our swallowing. Once it goes into the esophagus, we can have swallowing problems in the esophagus as well. So that is when we can have reflux, where it starts to go in and then it comes back up, or we can have stasis where it just doesn't move. For us to be able to assess swallowing, we will assess all 3 of stages for the safest and least restrictive diet. We we bring different textures and liquids. We present it at the bedside. We will look at how they chew their food, how long it takes for them to chew the food, how well they're able to transfer it to the back. If there's any coughing, throat clearing, sometimes we'll see a drop in O2 sats if the person is on oxygen. I have had patients too that they have to work so hard to breathe that to swallow just takes that extra breath that they're trying to get, and they end up getting fatigued, and they don't realize that they're stopping to eat, but the body is choosing to breathe. And so the body will just take away that need for hunger. There are times that we have to reduce the amount of work that they do to make sure that they get enough nutrition. So if we see concerns at the bedside, we may order an instrumental. And I'll look at chest x-rays. The other day I had a patient here at Shelbyville. He was a 90-year-old nursing home resident. He was on a thickened diet at the nursing home, came in, and his chest x-ray was clear. But when they did a CT of his chest, he had early stages of aspiration pneumonia. So I wanted to do a video on him to make sure that he was on the correct diet before he went back to the nursing home. He was a non-ambulatory man, and so his risk of aspiration pneumonia was very high. When to choose a swallow evaluation. If you are, have a family member or is working at the bedside, if they have any kind of pocketing, or if when they pocket and someone has to go in to remove that food, they probably need something. The oral sensory mechanism in their mouth can be reduced where they're not realizing that that food is in there. If they had a lot of throat clearing, coughing with meals, any kind of excessive weight loss. We saw this more in the nursing home setting, long-term care. They have troubles eating. Sometimes they have dementia and they can't tell you this, and so they just stop eating. And then we see wounds start to develop. And so when I worked in the nursing home setting, I would often look at the weight loss log in the wound care log and see if some of that. And oftentimes we did find that they had a swallowing mechanism difficulty that was not being picked up because they were not having throat clearing or coughing at the bedside. They were showing other signs that were not as visible to the naked eye. Sometimes they refuse to eat if they have multiple episodes of pneumonia. Sometimes if they report food sticking right here at the bottom of the throat, that can be that it's just hanging out over that UES and not working with the esophagus. Once we do that bedside and looking at a chart review, there may be things that we see that we need to do an x-ray. There's two different types that we can do objective measurements of the swallow study. The first one is called a modified barium swallow study. And the conception is this person has to be MPO. So for the doctors on there, if anybody is ordering these diets, they do not have to be MPO for this test. But we do go in the radiology suite. Radiologist has to be there to run the machine because it is an active movement x-ray. I will present different textures and liquids of food that have barium in them, and I'm trying to see if they are in fact going into the airway, and then I need to find out what is the best diet for them based on these views. I do have a sample of a swallow study. If you haven't seen one, it should be coming up next. Okay, so if you look on your left, we're going to see, you can go ahead and play that, Justin, if you don't mind. You're going to see on the left side, this is going to be a normal swallow. So the food should be going down by the spine and not into that airway. So as you see, nothing went in the airway. It's really hard to see. There is the epiglottis there, the little curly Q at the base. On that abnormal swallow, it's filling up, and there it went into the airway. And so at this point, it doesn't look like this patient is doing anything. Normally for you or me that don't have any issues, we will start coughing, clearing our throat. You'll hear, this went down the wrong pipe. But those patients, we would be given different consistencies and hopefully be able to find something that they could tolerate without it going in their airway. The other study that we can do is called a fiber optic endoscopic evaluation of a swallow. This is a little bit more invasive, and it's performed at bedside. So we will do these if we have someone that's morbidly obese and can't fit in the special chair that we have for these x-rays. Also, if we're concerned about vocal folds, one thing that I did not mention, we have actually two mechanisms that protect the airway. The first thing, the vocal folds close. So they have two jobs. They provide sound when we're speaking, but then they close, and then that epiglottis comes over and folds over them for the two protective measures over the airway. So if we have a stroke person and their voice is sounding different, or they're aphonic, they don't have any voice, so we may want to go in on an AP view. The bad side for MBSs is it's a lateral view. We can't see a whole lot. So we'll go in with the fees. It's the same scope that an ENT would use to go in the nose, and we'll park right over the airway. Then we put food coloring instead in their food. And so if aspiration does occur, we'll stain the inside musculature so we can see actually what happened with that. It is, as I said, it's more invasive, but there have been times when we have done it in the nursing home setting and we've actually seen maybe a cancer that we've had to refer them to ENT. I love the fees. I cannot do them yet. I don't have the hours required to perform it, but they're really interesting to watch if you ever get a chance to see one. So here's an example. So they have gone in through the nares and through the nose here, and we're looking straight down. So the dark spot in the center is the airway. The food is starting to head into that airway right there. We're looking through the vocal folds. It's a harder thing to see, but you can see at the bottom, the thing that looks like a potato chip there on the right side of the screen is the epiglottis. That is the flap that protects that airway. And so there is some yellow tinge right in that airway. They're scooting down into the airway to be able to see if it got tinged inside. So depending on what we find, either through a subjective study at the bedside or an objective study with either of those two measures, we may decide to put alterations to the diet. So this can include the thickened liquids such as nectar or honey thick. And those are exactly what they say. So nectar is about the consistency of tomato juice, and honey thick is as thick as honey. There is a third one that is called pudding thick. That is not one that I really prescribe because it just looks like food and it's hard to tell someone, yeah, here's your drink and it looks like pudding, so let's drink it. But these have increased weight, and so therefore they move slower through the oropharyngeal stage, so it allows for more time for those structures to get in place and protect the airway. We may change solids to a puree, a minced, or a softened bite size. Sometimes we may say no mixed consistency, and that is like peaches. You think about peaches with the juice or pears with the juice. Cereal is a solid and a liquid. So when we were trying to chew those, the liquid, our tongue forms a bowl and our teeth are chewing the solids. And then at the end, when we're ready to swallow, we take the liquid and combine it with the solids and try to head it back for a swallow. And there's times when the back of the tongue is just not strong enough to hold those liquids in, and they will aspirate over the back of the tongue. MPO, nothing by mouth. Those, we don't take that very lightly. We don't like to really make anybody MPO, but there are times that we have to do that in life or death situations. For intervention, swallowing exercises can help. There are a couple that we can work with to try to help strengthen those muscles. We also may give them some strategies to try. So with a stroke patient, maybe that has paralysis on the left side, it may have paralyzed one of their vocal folds. So we will have them turn their head when they're swallowing to give more room for that stronger vocal fold to help ease that swallow. We may ask them to do a chin tuck. So we just have them tuck their chin before the swallow, look at your belly button, and go to swallow. The theory behind this one is it closes off that airway a little bit more and allows more room for the food to go through the esophagus. Or we may have them do an effortful swallow where they hold their food in their mouth for just a second. They kind of do an oral prep, and we'll tell them to count to 3 and then swallow hard like they're swallowing a golf ball. And that increases that negative pressure that they need to try to get that food through the esophagus. There are times that cognition can affect swallowing abilities. I have had the person that maybe in a memory care facility that cognitively they forget to swallow the food pockets, and their body is not, their brain is just not telling their body that there's food there. So I've had to make people MPO because of that, because their brain just is not connecting to get that swallow going. So things to remember with quality of life. This has become really important to me. A little personal story that I haven't told. I was a late bloomer going back to school. My dad had emphysema and passed away at 62. And so he only had 10% of his lung left. And I did not understand all the implications. I had not gotten into graduate school. And so I would come home and he would want me to fix, his mind was sharp. And so he would be hungry for all this food, and I would cook it all and he would take a bite and then he wouldn't eat anymore. And I would get upset because I didn't understand, I just put all that work into the food. And so now that I have lost both parents, quality of life is a big push for me. So things to remember: that swallowing is the hardest thing our body does, and eating is the last pleasure that we have in life. Eating has always been a social endeavor. So there are times in the elderly population, and sometimes, in the rare case, it is a younger person, maybe with ALS or something like that. Quality of life versus the risk of aspiration. We have to look at this. One thing that I really appreciate here at Shelbyville, Dr. Val Breons Pryor is our physician here, and I love her dearly. We get a lot of nursing home patients out here at this rural hospital, and there are times that we'll get a 92, 93-year-old person, and they come in because they've been choking, and I'll go and do a swallow study and tell her, they need to be on puree and honey thick liquids, and their overall quality of life is not good anyway. And so she said, okay, it's time for a hospice consult with this person because I wouldn't want to eat that. And, we've had this history of aspiration pneumonia. And so it's some hard discussions sometimes to talk to the family. We always have to offer a peg tube, but, at 92, 93, quality of life with a feeding tube is not the best. And so just reminding them that eating is the last pleasure that we have. The body will stop eating as it gets closer to death. And those are just individual assessments that we have to make. But anyway, I've learned a lot in this trek, and I am looking forward to any questions that you all have. I hope you've learned something new, and thank you for having me.
Oh, I think we have learned quite a bit. I think you probably could do a three-part series on this. Thank you so much. This really resonates with me. As I was telling you earlier, both my stepfather and my grandmother passed away from aspiration pneumonia.
Well,
Um,
and until you go through it, Dr.
yeah.
Yankelov, you don't understand it. Sometimes when I'm talking to these patients, they're looking at me like you're telling them to eat, and my husband just lost his stepdad or his father 2 weeks ago, and he understood. We had to do the same thing, and he goes, I get it now. You want to make them happy and comfortable in their last days. Yes, absolutely.
And just from one of your first slides, 26 muscles involved in
Six
swallowing.
muscles. Yes, ma'am.
I was wondering, one of the things that my mom was having a hard time was taking my stepfather out because he was coughing and the embarrassment that she was feeling, even
Yes,
though
ma'am.
there were a variety of things that she was using, Thicket and things like that, but also the social, and people wouldn't come and visit because also it was scary for them and that kind of thing. I also wonder if you could speak to that from a standpoint of both from just a humanity standpoint. How is it that what we can do when these things are happening?
Well, it is hard. As we are getting closer to losing a loved one, sometimes you want to provide everything. You don't want to let him go. And often Dr. Val and I always talk about that when we are trying to we are trying to be empathetic and compassionate to what's going on. Yes, there is a social endeavor to that if you have someone that coughs and chokes all the time, everybody's going to be looking at them. It's embarrassing. It's embarrassing for the person that's coughing. It's embarrassing for the family member. And in those times, it is hard to say, okay, in those settings, maybe you want to try to just give them less to eat or figure out things that they can eat without all of that and present that with them during that time, because we often forget as a family member, we don't want to let that person go, or it's always about us and not thinking what that person is feeling. And so many times now I have told people, if I'm like my daughter's an NP down at Jewish, and I've told her many times, don't ever put me on this thick and liquid because I don't want it. The risk of hydration, the risk of dehydration is much more because they don't want it. The pureed food, it looks like baby food. I don't want it. It's not appealing. And so I spend a lot of time on the caregiver side of it. I have a little app that probably is the best $15 I have spent in my career. And Dr. Manon here, he'll pull me up there when he's trying to talk to a family member about quality of life at the end of life. And they're not getting it. They're not understanding it. And he'll say, can you come up here, please, and talk to this family and bring your little video so they can see what's going on. So it's hard. It's hard all the way around. And I think a lot of that is we don't want our person to suffer. We don't want them, but at the same time, we don't want to let them go. So it's a very, very thin line. And it is something that you truly don't understand sometimes until you've been through it yourself
Yeah.
with a family member.
Thank you. I think we have a question. Amanda's asking, do you see many young people with dysphagia due to atomia following PTSD? And if so, what is the treatment for these patients?
Swallowing can be a psych issue. I do see some swallowing problems with pediatrics. It can, so speech therapy, I'm not sure if everyone knows, we cover so many different things, but we actually go into the neonatal units for preemies, teaching them the suck swallow pattern. Up until my oldest patient's been 106. So we just see the spectrum. It's been such a blessing to think I got in this degree because I wanted to be the little person doing sign language in the corner of the screen. And I am so far from that. But it has been such a blessing learning all this. But sight can impact swallowing. It can also impact voice. I've had patients come in that have had PTSD that can't talk. Just the stress and the psych of it will lock their vocal folds and they can't communicate. So it's interesting how swallowing can be impacted by pretty much anything.
Mm, okay. Let's see, Paul, would you like to come off mute and ask your question? Dr. Salmon, would you like to turn on your mic and ask?
I thought I had.
Okay.
Thank you so much. It was very informative. I wondered if you've worked with anyone with Lewy body dementia for whom swallowing is becoming increasingly challenging. This is for an immediate family member, and I wondered if there is anything especially unique to this condition that sort of, kind of impacts how you would approach working with them.
So if they have Lewy body, I'm assuming then they also have Parkinson's disease.
Mhm.
Is that true? Yeah, because those usually go hand in
Yes,
hand.
right.
Yes. And so in Parkinson's patients, the statistics are that by the end of the progression, 90% to 100% of those patients, whether they have Lewy body or not, will have a swallowing problem. It is just known in that population with Parkinson's because of the hardening of all the structures due to the
Oh.
Parkinson's.
Mhm.
Yeah, and about 50% of those people with Parkinson's will have a cognitive disorder in addition.
Uh-huh. Yeah. So the Parkinson's may be the primary factor in terms of contributing to the difficulty
Yes,
swallowing.
sir. Yes, sir,
Mhm.
because the structures are not going to be moving. Sometimes you will see the epiglottis will just get fixed, and it will not move at all. And so when it does not move at all, it does not protect the airway. And
Mhm.
I've had patients where I've just given them a swallow of a bite of food, and it just heads straight to the airway. Nothing moves.
Mhm.
And yeah, that's unfortunate for Parkinson's, but that is one of their um, risk factors,
Mhm.
unfortunately.
Mhm.
Yeah.
Well, thank you so
Now,
much.
sometimes with the people with the Lewy body or with the cognitive dementia, I have had to they lose the taste in their mouth. And so they'll stop eating because they can't taste anything. So if you think about yourself with a cold, nothing tastes good and you don't want to eat. So the last taste bud that we have is our sweet taste bud. So that's why a lot of the elderly, they'll eat all their sweets, but they won't eat
Mm,
anything else. So I've had the patients where I've had to put pudding on the bottom of the spoon, or I've had to put a bite of cake on the end. I had to figure out where they taste it first to encourage them to eat.
mm,
Or sometimes we have to give them food with cranberry or grape juice to trigger the swallow. If you think about lemonade, those tart drinks, the first thing you do, you start getting saliva. Just thinking about it, you get saliva built up in the back of your mouth because your brain is triggered. It's a sour taste, and your saliva is getting ready for that. And so we've had to recommend sour boluses for them to eat their food to help trigger the swallow and move it through the oral transit phase.
mm.
Yeah.
All right.
Thank you so much. Mhm.
Thank you. Thank you for the question. Chandler, would you like to go and ask your question?
Yeah, I know of an older adult who, whenever they eat, and sometimes when they swallow their food, sometimes I guess it goes down the wrong pipe, like a lot, and they start having these really like violent, like coughing spells. Their eyes get really watery, and like sometimes even when they cough, it's like they're losing their breath, like after they cough. Is there anything that you can do in the moment?
Unfortunately, there is not. I'll see people slapping people on the back, holding their arms up, doing all the old stuff. And no, none of that really helps. So when we're coughing like that, our body's reaction for those of us who have a healthy swallow, the first thing when it goes into the airway, the body starts sending up those bursts of air, and that's your lung trying to protect. And that's why we're coughing. Those bursts of air are coming up from the lungs to eject that stuff out. And so there's really not anything you can do when I am trying to upgrade someone in the hospital setting. If I go to give them a drink and they have a reaction like that, I just remain calm, rub their back, and I'm presenting them to be calm because it is scary. I have almost choked like that before, and you just can't get that big breath to get that one push out. The biggest thing is just not to panic, and try to keep them calm. For the emphysema patients and the COPD patients, my dad had that happen one time, and his anxiety kicked in to the point that his body just passed out. That's what his body did to try to reset to get him breathing again. But yeah, you just got to stay calm, unfortunately.
All
Yeah,
right. Thank
it's
you.
tough. Sure, thank you.
And Christy, we have two more questions, I think, before we go on to the
Oh,
case.
goodness, good. Okay.
Um, is there methods to strengthen those 26
Yes,
muscles
ma'am.
from
Mhm. There
darkest?
sure are. There's a couple of things that we can do. There is something called Vital Stem, and so it's an e-stem machine that we can put on the jaws, or sometimes we'll put it here on the throat, and we'll send electrical impulses into those muscles to try to regenerate them and get them working, and then get them triggering in sync with each other. There's also ones called Shakir exercises where we lay them on the back of the bed and we just have them lift their head, and that triggers the response of the muscles to flap, cause the flap to fold over the epiglottis. We're limited on exercises. We don't have as many as PT and OT. There's one where we hold our tongue between our teeth. It's called the Masako maneuver. We hold our tongue between our teeth and swallow that way. We may, have them do this effortful swallow. Some of them, there's one called a Mendelssohn. So there's not a ton. And in the outpatient setting, I will present those exercises. It's different than PT or OT. Well, PT will have you come and they can increase the weights and increase the reps. For us, it's not that way. It's just the point of the patient doing the exercises daily at home to strengthen those muscles.
Thank you.
Sure.
And then I think we're going to take one more. We're going to take Barbara's question. Did you want me to read it? Or you want to? Oh, okay. Can people who are concerned about their swallowing due to things that they're experiencing daily but don't have a chronic condition get a swallowing test?
Absolutely. Just need to order from your doctor.
All right. Thank you, Christy. I hope you can stay on for our presentation. Usually there's a connection between the two.
Yes. Thank
All
you.
right. And I'm sorry if I didn't get to everybody else's questions. We'll see if we can get you Christy's email. All right. Recommendations are going to be taken by Dr. Samantha Cotton. Thank you so much. And we're going to have a presentation by Amanda Riesling. Thank you so much, Amanda, for bringing this case today. And whenever you're ready.
All right. So this patient is an older adult veteran of the Korean War. He is a Black man. He's 91. He was a longtime caregiver for his wife with Alzheimer's and is a recent widower. He receives VA primary care. Through a trauma-informed lens, the client experienced multiple system issues that compounded harm at the end of his wife's life. Restricted visitation, conflicting guidance, and information, unsafe transitions that undermined his safety, choice, and trust, which seemed to have impacted and escalated his symptoms, grief, sleep disturbance, chronic pain, increased dysphagia symptoms, and executive function strain. So the key questions for this presentation are: what trauma-informed workflows could prevent harms like those he experienced while adding brief, scalable supports for mild cognitive decline and multi-step processes, and integrating sensitive symptom care into the plan? And then the other question is, could nervous system dysregulation, secondary trauma, during caregiving and his spouse's decline have contributed to his dysphagia, and how should that inform care and recommendations for him? So His primary diagnoses are aortic valve stenosis, heart murmur, hypertension, hyperlipidemia, dysphagia, urinary incontinence, and an enlarged bladder. 67, 67 inches tall, 160 pounds, BMI of 25.1. Blood pressure with medication is 124/77, LDL 89.8, and HDL 67. So as far as his biological sphere, his functional limitation is he's independent at 91 with taking care of all his own activities of daily living. They were previously very, very strained by caregiving. He is ambulatory without device, but he is moving slow. Chronic right ankle hardware pain limits prolonged standing and walking and makes stairs very difficult. Fatigue is prominent, and his sleep was fragmented for a long period of time due to caregiving, end-stage Alzheimer's, and dysphagia. He has a little trouble. He said when he's sleeping, he'll wake up coughing due to saliva. Cognitive function, there's no recent MOGA on file, mild deficits in organization and task initiation consistent with cognitive decline changes, which contribute to delays with forms and deadlines. He really struggled, and my experience with that was him trying to get his Medicaid paperwork in for his wife at the end of her life. It was really, really difficult. Where he would try to go take the paper. I was even reminding him, like, okay, today you need to take this paper down there. But then he got down there and he had the wrong paper and just different things like that. He's got significant symptoms, chronic ankle pain. He said it's about a 6 to a 7 out of 10 daily, urinary frequency and retention history, insomnia, increased dysphagia recently, and a lot of daytime tiredness, no tobacco or alcohol. The medications that he takes, you guys can just read them there because I'm sure that I will butcher the names. His nutrition, his BMI is less than 25. He does eat adequately with Meals on Wheels support, and there hasn't been any recent weight loss or unintentional weight loss. So education, that is unclear if he graduated high school or not. He is a veteran and he does prefer plain language, step-by-step materials, and does need reminders for forms and deadlines. Advanced directives and power of his attorney was encouraged, but none at this time because there was no appropriate surrogate identified for him to name. And then I was his case manager through the caregiver program, and that was my connection with him. And so that got deferred due to the focus on Medicaid paperwork to pay for his wife's care until later. And so he's in very deep grief after her recent loss. So we'll revisit that when his bandwidth allows. He drives independently, but he will only drive during the day and doesn't want to go very far. His ankle pain slows pace, but he has been open to community ride options as a backup. He is on a fixed income and he has VA benefits. His housing is stable. Short-term strain is always possible during kind of benefits navigation. That's really difficult for him to work within the systems and the things they require. He would definitely benefit from case management support for paperwork, billing, and deadlines, but he is no longer a part of the caregiver program now that his wife has passed. So I would love a recommendation on how to get him some case management support because I moved out of that role into behavioral health. So he's experiencing a lot of acute grief and stress responses. Ever since his spouse was hospitalized initially, he reported sleep disruption, hypervigilant, and intrusive distress. mild anxiety and depressive symptoms, and no substance use issues. He is of Christian faith. Prior religious messaging equated counseling contributing to refusal of behavioral health counseling. Um, he does prefer Christian faith congruent language, trauma-informed, non-pathologizing, that word is always a struggle for me, approaches when needed. And he has actually restarted some of his spiritual support since his wife passed, because now he can go to church on Sunday. So he is doing that. And I think we already covered education. I don't know why I doubled that. He does live alone, and he does have kind of informal supports like Meals on Wheels. He does like daily activity, takes care of everything in the house, but also still limited by his pain and fatigue. He is open to doing gentle walking, stretching, but would definitely need pace, low impact options. Um, he eats regular but very simple meals and not a wide range of the different types of food, because he said certain things just make him choke. So he kind of sticks to his same few things. Um, I have encouraged him to make sure to hydrate, because that's not something that he remembers to do, is to drink water. And he does generally take meds as prescribed, and he does use PRN, acetaminophen, and the occasional like Tylenol PM. The executive function challenges, my concern is that could affect like refills, timing, and thinking maybe he might need a pill box or something as he's having some mild cognitive decline. And oh, sorry. I wondered about a PCP review of sleep aid, just because I know that there's certain patients of that age that shouldn't be taking Tylenol PM. So he is established with VA primary care, and he does use systems reliably when the appointments are set, and he has reminders. Um, he does have his daily meds on hand and generally gets his refills timely. Occasional issues with that. Occasional help is useful for reminders and organization. He does have access to mental health services, but due to his religious beliefs, will not access them. Satisfaction with care mixed. I mean, his routine care with the VA is pretty acceptable, and for the most part, most of his medical needs are being taken care of, but there's significant dissatisfaction with hospital discharge and communication around his spouse's psychiatric admission and his limited visitation, and then the transition to care after that. I don't have any data on his dental care. There are fall hazards just because of his slowed gait and ankle pain. We did discuss how the stairs and throw rugs could pose a risk, and I recommended that he bring those up. But I wondered about a walkthrough and some simple fixes, maybe, just because he does struggle from recommendation to completing task. Um, I don't know when they've been tested, but he did say yes, he did have smoke detectors in the home, and I'm not sure about carbon monoxide. Um, his home hygiene is adequate. He's been taking care of things for a long time, but heavier tasks can lapse like during grief and fatigue periods. Um, Short burst routines, or maybe like a light homemaker support recommendation would be good. He's completely independent on his personal hygiene, but his energy fluctuates to execute. He is traumatized, secondarily traumatized because he was a Korean War vet, by his spouse's psychiatric hospitalization, limited visitation, conflicting information from professionals, transitions of care. There was also a transport accident resulting in a femoral fracture of his wife. Um, they were unable to manage her pain and also unable to surgically fix the leg because of her state and then her subsequent death. He has a lack of close social support. He doesn't have any children, and her son lives very far away and wasn't very engaged. Um, Even though he's returned to church, he hasn't really kind of integrated there yet. So he's not talking to a lot of people outside of just going there for that hour at this point. So these are all the different areas of that he has been a part of, kind of like the systems like VA primary care and nursing, the hospital psychiatry, caregiver program, which is where I came into contact with him. Behavioral health has been recommended but denied. Medicaid, that has been discontinued now that she has passed away. He does engage in community services with the meals, but I was wondering about homemaker and transport as his cognitive decline advances. Um, and then I was curious about maybe a additional pharmacy that could maybe do it on a loop where he didn't have to do anything to get his meds to make sure he doesn't ever run out. And then faith church contacts. And so kind of going back to the key questions that I was hoping for recommendations is what trauma-informed workflows can prevent harms like those he experienced while adding brief scalable supports for mild cognitive decline and multi-step processes and integrating sensitive symptom care into the plan. And could nervous system dysregulation and then the secondary trauma during caregiving and his spouse's decline and then death have contributed to his worsening dysphagia symptoms? And how should that inform his care now?
Hmm. Thank you, Amanda. I really appreciate that very comprehensive presentation. Christy, I was wondering if maybe Christy could begin with question 2. Is Christy still with us?
Yes, I'm here.
There you are. Sorry.
I was thinking a lot of stuff through that.
Yes, I
Uh,
bet you were.
yes. So the cognitive piece, if this was my patient, he definitely could benefit from therapy. I don't know if therapy, PT and OT, OT can go in and help with his ADLs, and then PT could help with strengthening, the walk and getting him safe to ambulate. From a cognitive standpoint, speech could also come in, but I think that the depression from the recent spousal loss has something to do with it. I would also question about him being assessed for PTSD from being in the Korean War. I have new experience with that, unfortunately, with my husband being in Desert Storm. We are walking through this battle with PTSD now. And so that can impact quite a bit. And absolutely, some of that depression can impact his swallowing. And if he is not eating a lot, I noticed that he didn't have any weight loss, but he very well could just be cognitively from the depression, not be wanting to eat. He may not be able to even taste his foods. But if he's having some trouble with an executive level cognitive functioning, he also may not be able to prepare the meals that he likes. And sometimes it's just easier to not eat because it's too much work to get up and try to do that. So there's a lot of different things that I saw in there that he could benefit from some disciplines for care. I just don't know if it's available in the setting for him.
Amanda, what was he? You said he has a few things he eats.
Yeah, I mean, and I think it's kind of like she said, thicker stuff. like the puddings, and he said that he'll do like stews and different things like that, but then sometimes he'll choke, which makes sense what you said about the mix of the liquid. So I'm going to make sure and tell him about that. Um, but he wasn't really specific, and he does eat, but he eats the same things whenever it's him making it, like you said, but then he does have that Meals on Wheels. But he said sometimes when they bring certain things, he chokes too much, so he can only eat some of it because it's not exactly consistent. Just know if you can let them know there's dysphagia issues and they adjust what they bring, or
I don't think that's how that works. Those Meals on Wheels are they're volunteer providers and they cook one meal and they provide it for everyone. And then it's only I think it's once a day that they bring one meal. And so while a nice it's a nice thing to supplement, it's not enough to keep them hungry. And so I also was wondering, just the depression, we can just see a lot. I have to ask that a lot of times with my patients that are not wanting to eat a whole lot. They can't taste things. If they're having trouble, just if he's having trouble swallowing, um, it he probably needs to be assessed. It's hard to, see without actually seeing what's going on with him. Sometimes you can have a single choking episode. I've had patients that have had one single choking episode, and then they have that PTSD from swallowing because they had a choking episode. So then they won't eat because they're afraid to eat, even though they could eat because that was a singular event. Yeah. So I think poor little guy with all of the stuff he's going through, it's yeah. And then so if he's not eating enough, then that of course is going to impact the ability and the strength for all the other things.
Amanda, do you think he would be receptive to getting assessment, or do you think that's going to be another thing that's engaging with the healthcare system that's going to be like, no? And if so, Christy, is there a way to present it?
well, so I think definitely he would do the swallow study, anything that's like medically, but I don't know if he would go for the PTSD because he kind of, like that whole older adult cultural thing where they think
You don't talk
we're
about it.
not being faithful, kind of thing. So I will try and I will say that it was recommended whenever I called him, but I don't know that he'll go for that. Is there language I can use when I talk to him to?
Well, so if I can go back to a personal thing again, so my husband, we've been married 28 years, and when it came out that he had it, he fought it. And he's like, I don't know, I didn't see my friends get blown up in the field. I can't have PTSD. So it took 2 or 3 months. And finally, when he was going to therapy for it, they said, well, you are a person that has had trauma. And when they put it to him that way, as opposed to PTSD, because PTSD is so much now for veterans and soldiers that have seen things happen in the field. And so when they reversed it, because my husband was the same thing, you don't talk about that stuff, and so when they reversed it to a person who's had trauma. And sometimes these familial things, losing a spouse, will increase all of the effects. Maybe that, for 28 years, my husband's able to suppress this whole PTSD stuff. And in the last 6 months, life has changed. And so it very well could be with him, with the death of his wife. He may have had some of these things and just been able to suppress it, which it's amazing how the brain and the dementia and the cognitive piece of it can affect the swallowing so much and the ability to want to eat. You might want to just say, hey, maybe let's just get assessed. Maybe you've had some trauma from before, but definitely seeing all the things. I mean, it's obvious in your presentation, he's had traumatic experience with his wife and the psychiatric evaluation. That's upsetting to anybody. And so he's got kind of a double whammy there.
Well,
oh, yeah, or triple
there
whammy.
was a multiple, like first he couldn't get the Medicaid done. He knew she needed long-term care. So she had an episode in the middle of the night. After like the fifth time, he took her into the emergency room. They put her into the psych hospital. And then even with multiple people advocating for him, because he kept saying, I can't take her home like this. I'm 91. I'm not physically capable. I don't know what to do. And they sent her home anyway.
Mm.
And then when the hospice person came back out because when she was in the psych hospital, the hospice person said she was not ready for hospice. So then after they sent her home unexpectedly, then a social worker got out there and a palliative care or hospice person reassessed her, said she was ready. And then when they went to move her, they dropped her coming out of the house and broke her femur. And then she spent the last 2 weeks of her life in agonizing pain. So it was boom, 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 boom. So if
And
he was able to keep all those kind of symptoms under wraps for many years, I could see how that experience would amplify greatly and cause symptom.
well, and then the other piece that we're missing in that is there's probably a ton of guilt on his part.
Yeah.
And he's not knowing how to handle that guilt. Because he didn't take care of her to the best of his ability because he was limited. And it's just a waterfall that it's heartbreaking. And then on the other side, we see this a lot. When I was in the nursing home, managing in the nursing homes, these insurance are saying, hey, you're walking 10 feet. You can go home now. And you fight and fight it, and they don't care. They don't want to pay that bill, and they're going to send you home. And so then you're just kind of stuck, and it's cruel. And there's not a whole lot to do about all of that. Unfortunately, we just got to keep fighting. But I think he's just missing, he has a lot of things going between the guilt and then all of these other exacerbated symptoms. I'm not surprised that he's not eating very much. And if he's having trouble swallowing, why he wouldn't want to eat anymore. Death of a spouse is a big deal, especially if they've been married for a long time.
It is. So Sophia Banks in the chat. Sophia, I don't know if you want to come off mute and talk about it, but it says the VA has a prescription delivery service.
They do.
Familiar with that? Sophia.
I think Amanda actually already answered to that too. Amanda Wang, not Amanda R.
Yes.
You probably
Yeah,
know better.
Amanda Wang says that the VA typically mails medications anyway, with some of them autofill and some of you have to fill when you need it. Yes. And then Paula, did you want to jump in here and just share what you shared in chat? Okay. Paula indicated that home delivered meals in Pennyrile are a regular diet. We subcontract with senior centers to prepare the meals. However, if you have the opportunity through mom's meals, they may be therapeutic options, but not sure. So that's something there. And then Amanda Wang, you wanted to go on and say something. Feel free to.
Yes.
Yeah.
Hey, hello, Amanda. It's actually really sad to hear how quickly and terribly this situation has just fallen apart from when you did this case conceptualization on a Wednesday, not too long ago. So I'm sad to hear that. But a couple of things is he seen primarily through the VA or no? So the VA as a whole advertises and should have programs across the board for in-home care, in-home primary care, in-home rehabilitation services, PT, OT, and I can send you a link from their website that, says all these things and like who's eligible and whatever else. Because I just dug into a lot of information for the national case competition that we did. Also, they should have case management services. I don't, it obviously be, what is he able to do, requests, whatever, on his own, and what he's willing to accept. Yeah. So it might be.
That was kind of my thing is I'm like, I'm not on his case anymore, but that's okay. I'm happy to call and like make the recommend, but I don't know how to make that connection. How do you help him get those services when he's not able because of the cognitive decline to navigate those systems?
Right. So Amanda Benjamin has some more information on getting hold of someone for those services. Before I hand off to her, which I know therapy and mental health services is like no, we don't want that. But in my experience, a lot of time churches have some sort of counseling, pastoral counseling Um, maybe he would be more open to that if it came from the church, even if it's just grief counseling.
It's true.
Good idea. Yeah.
Mhm. A lot of times those home health services, they have to be homebound in order for them to get home health. So if he's still driving, that would most likely disqualify him from the PTOT and ST coming to his house. He would have to go to outpatient. And they do have outpatient services at the VA, I believe.
He hasn't had any trouble getting to his medical appointments or anything like that with a little reminder, but I like the idea of trying to get him a case manager through VA that can do that for him and help him.
Right.
Yeah.
Mhm. Any other comments, even related to the first question? Comments or suggestions? And in particular, was there something for the first question that you wanted to lean into?
Well, I kind of saw the problem when you're having that mild cognitive decline, especially with him being a caregiver and taking care of someone else. I mean, that's a lot of overload. It's like, how can we as social work professionals help them through that process in a way that's meaningful? I mean, I would put on my calendar, he needs to go, and have this paperwork in by this date, and then I would call him and remind them, but then he would, you know what I mean, take the wrong is I think I'm looking for more of like an assessment of how could I have done that better. So the next patient, I can help connect them to better services, make sure there's not delays in care due to a lack of Medicaid coverage. Do you know what I mean?
Yes.
Like, is there a process that's better? I mean, I'm new, I'm just a student, so I'm like, help me.
Yes.
This is Sam. I'll just jump in here. Not necessarily about the process, because right, the process is cumbersome in and of itself. But I do think there's something to be said for a couple of things that you've noted in the course of discussing this patient, in that one, he's undergoing this grief, right? Plus, there's this potential cognitive impairment or cognitive decline that you're seeing. That could be a number of different things, including being exacerbated by the grief. And so we sort of have to honor that and understand that that could be part of this. And also just the stress that he was under in terms of taking care of the spouse, right? I think a few things come to mind for me. It sounds like he does need some additional support, like on a day-to-day level. And so investigating that could really help in terms of some of these other things you're talking about. Like, you mentioned forgetting to hydrate, forgetting to drink water or fluids. Some of the paperwork related things, it does sound like he really does need somebody more constant in his life. You're not going to be able to, in your role, fill all of those needs, right? But helping whoever that person is, I think would be really amazing. And the other thing that came up, and I don't want us to ignore this, even though I know this wasn't really a large part of our conversation, advanced care planning. I noticed you mentioned that that discussion had been difficult because there wasn't somebody for him to select in some of those roles that he needed. But I think maybe revisiting that is part of this larger discussion about, potential for caregiving, I think is important because I'm getting the sense that there's much more needed than what you're probably even seeing from your end. And I don't know, Justin, if you wanted to add anything about advanced care planning or advanced directives. It's just that's something that stuck out to me when you were speaking earlier and adds to your question.
I mean, this is something that is a real challenge for people that don't have particularly close next of kin, or they feel, especially like, with older adults who feel like their social circle is getting smaller. I don't know if there's like a technical term, but I've heard elder orphan kind of tossed around. I don't love it, but it's, kind of speaks to that, people not having a real close person. I know that sometimes people can have somebody through the area agency on aging. I had a friend who had a power of attorney through the area agency on aging when they moved here. So, I mean, maybe either through the VA, there might be some kind of situation where they could connect them with someone that would understand and take the time to understand their values and be there their healthcare surrogate if they couldn't speak for themselves, or as their dementia progresses and they're unable to speak for themselves, making sure that there's somebody that at least knows that. And hopefully he doesn't, it doesn't come to guardianship, but, having this conversation in advance with people would be a really good way to support him and make sure his values are honored.
Yeah. Okay, I think what we're going to go on and do is we're going to go on and transition to the next part of our Project Echo. So thank you, Amanda. That was a tough case, and we wish the best. All right, so Justin, I think you're going to go on and take over the Kentucky Coalition for Healthy Communities.
Yeah, so thank you for sticking with us. The Kentucky Coalition for Healthy Communities really working to train and empower stakeholders and community members to provide hope and education for their communities. And so I learned so much today, and so I'm just really interested in hearing what did you learn and how will you share this information with the people either in your lives professionally or in your community. Any ideas of how to share this information and help it spread?
I'm going to be asking my PCP for a swallow study. So great information.
Yeah, thank you, Amanda. Anybody else? Please know that this session is recorded, so I will be sharing this in iEcho under the resource section, so you're more than welcome to share this with anybody who would benefit. Okay, so anything that you'd like to share going on in your communities and your organization that you would like to share with the group? I will share that if you are in Louisville, I have volunteered for a long time for a food pantry on the first Saturday of the month. It's a drive-through food pantry from roughly 7:45 to 9. We have a spot on off of Bardstown Road behind the Eagle. So it's a drive-through food pantry. No one's turned away, and there's no proof of need or anything like that. Just showing up is how that works. So if you have anything going on in your community you'd like to share in the chat or in your organization, please let us know.
Hey, Justin, this is Susan Howard in Owensboro, and I'd like to share that for those of you that are in Western Kentucky, our Green River Area Development District is taking donations of items and money for their Silver Bells project, where they provide residents in personal care homes with gifts or items that they may need at Christmas. And the second thing, specifically at Brescia University, that in fall 26, we will be taking our first cohort of PA students. So Brescia University now has a physician assistant graduate program. And so you might just, get the word out for those people who might be interested in seeking a PA degree, that Brescia University now has that.
Thank you. Anybody else have anything going on in your community or place of work you'd like to share?
You can just take off your mic. Yeah.
Oh, okay. Yeah, just an announcement. Livestrong program at the YMCA is open to people at any stage of the cancer journey. We just completed a fall program yesterday through Norton Commons YMCA. I have a connection between the YMCA and also Gilda's Club, where I've taught mindfulness meditation for many, many years. But we've put together a program that integrates the standard Livestrong curriculum, which is exercise oriented with a mindfulness element. And we will be recruiting for our next program, which will start up shortly after the first of the year. So if anybody wants to reach out, I could put my contact information in the chat box I'll put an email address if anybody wants to reach out. Thank you.
Thank you.
Hey, Justin.
Yes.
I know that there are probably a lot of churches that are in the process of giving away food with active food pantries. But if you are in Louisville, Kentucky, and you know of a family that needs food, Kingdom Fellowship Christian Life Center, it's my church, uh, um, down 324 East Broadway that sits right across the street from Norton Pavilion, is has been giving away food, courtesy of our nonprofit arm, Life Development Corp. From, let's see, Monday through Friday from 9 to 3, I believe. And we'll be this is not just for the sake of Thanksgiving, but this will be ongoing, particularly, especially through the holiday season, but into next year as well. So if you know of any families or any elderly or any person that may need some food, that it is available and they can come by and get that food. Sure, I can type it in the chat.
Yeah, thank you.
All right, great. I can do that. Thanks.
All right, thank you. All right. Well, if you ever have any events that you'd like to share or anything in advance, please let me know, and we can be sure to share that during the KCHC meeting and in my follow-up email. So My Health Matters meets on on Mondays from 6:30 to 7:30. Coming up on the 24th, we have Emotional Grief in the Holidays with Miss Barbara Gordon. We have Holiday Fun with Chandler on December 1st, and on December 8th, we have a concert, Songs for the Souls. So please, if you have any questions or anything, please reach out. We would love for you to join us. We have a diabetes self-management class coming soon, so register now for January 2026. If you know anyone who is 60 plus, preference is given to 60 people 60 plus that are struggling to manage their diabetes or would like to learn how to do this more effectively, please reach out. We would love for them to join our next cohort in January. We also have Flourishing Together, which starts in February. This is really around healthy behaviors and activities. It's a cohort-based group that really learns some really good skills together and really encourages each other to engage in more healthy lifestyles. We have a lot of programs really focused around helping older adults flourish. Our Flourish Care program, our caregiver program, our virtual friendly visitor program, and then Pearls. So, please reach out if there's anything that would be supportive for you or anyone that you're supporting in your communities. And then if you would like to learn more about caring for older adults and learn more about aging, we would love for you to join our Optimal Aging Scholar program. Here are some of the program requirements. Basically, we have a series of online modules. We have an interprofessional case management experience. Attending the Project Echo session is one of the requirements. And then we have a deep dive into age-friendly healthcare principles through our Impact 4M training, and then participation in our Optimal Aging Conference. So if you're interested in becoming an Optimal Aging Scholar, please reach out to me and I can connect you with the right people. And we have some community initiatives, our Flourish Care Centers of Excellence, really working to work with our area agencies on aging and their regions to really help infuse, really excellent, care and coordination for older adults. And so I would invite you to reach out to Mr. Chandler House is coordinating in the Cumberland Valley area, and we're going to be working in the Kipta and the Barren River Area Development District areas as well in the coming new year. So really appreciate you being here. We're really working to become an effective state coalition to really empower people and community members to become a healthier, more compassionate people. And so we really invite you to be taking what we're learning and applying it to yourself and the people in your lives, and to really help us become healthier. This is our upcoming schedule. Again, December 12th, we'll be learning about blue zones and healthy aging. On January 16th, Mona Huff will be talking about living life celebrations and speaking from her own personal experience. It's a really powerful session, so I hope you'll join us. And then in February, we're looking at the power and purpose of and social connection and aging well. So really just appreciate you being here. Hope that you have a nice holiday season. I hope you're acclimating to the, well, if you're in Louisville, at least today, it's rainy and cold, so hopefully you're adapting to that okay. If you would like a certificate, please complete the evaluation. If you are a community health worker or a social worker that would like continuing education, you must complete an evaluation. So we really appreciate your feedback and hope you will join us next time on December 12th. And if I don't see you, I hope you have a great holiday season and rest of your year.
And once again, thank you, Christi, and thank you, Amanda.